Thank you. Up to this point, a lot of what we've been talking about is we've talked about the MCHAT and the importance of assessment within a primary care context, and that is very important. I think what we often don't realize is the importance of primary care as part of the sort of treatment toolbox for autism. We talk a lot about specialty care like ABA therapy, speech-language pathology, occupational therapy, and these things are all important. But there's also a very important role that primary care plays in the ongoing management of autism. As we talked about, as David touched on, there's a lot of comorbidities, and it's not a single issue that we're dealing with. One of the common things that we see with children on the autism spectrum are sleep disorders. I have a little bit of time to talk about a big subject, so what I really want to focus on today is one specific sleep disorder, the most common, which is insomnia. So some statistics for you. The prevalence rate of sleep disorders among children with autism is somewhere between 53 to 78%, depending on what study you look at. So over half of all children with autism have a lifetime risk of a sleep disorder. Compare that to the general population, which is somewhere between 26 and 32%. So pretty large risk and significantly greater risk than in the general population. As I mentioned, insomnia is the most common of the sleep disorders that children with autism are affected by. Insomnia can include both difficulty initiating sleep and difficulty maintaining sleep, and we see both of those issues with autistic children. There are some differences between insomnia in children with and without autism. So children, neurotypical children, typically developing children, we usually think of the main factor causing insomnia as being behavioral in nature. By contrast, kids with autism have a multifactorial etiology. So there's behavioral factors that play a role. There's been recent studies that show the role of sensory sensitivities and how they impact sleep. There's medical and neurological issues that can be contributing, and then psychiatric conditions. So all of these things together can really impact sleep in children with ASD. Autistic children with insomnia are at higher risk for severe behavioral disturbances during daytime. So all kids who lack sleep have problems the next day, and sometimes I think we undervalue how significant sleep can be on daytime behaviors. With children on the autism spectrum, some of the things that we can see as manifesting more severely would be repetitive behaviors, irritability and agitation, and so on and so forth. And there's been studies that have shown if you attend to the sleep disorder, there is improvement in those daytime behaviors. So just attending to sleep alone can help manage autism more holistically. There's been a lot of research, and there's 3 studies that I've cited at the end of this slideshow that have looked at sleep disorders and the extent to which they are detected in primary care. So these studies are not specific to ASD. They're looking at the general population, but the take-home message is that even within the general population at a prevalence of between 26 to 32%, this is not something that is as routinely being evaluated and addressed as should be. It becomes even of greater relevance when you're talking about a child with ASD because of the higher prevalence rate. So a lot of what I'm going to be talking about today is a specific clinical pathway for insomnia in children with ASD. And this is based largely on research that was done by the Autism Treatment Network's Sleep Committee. So they, and you can find this study pretty easily through a Google search. I've included in the references, I've included the name of the study, but it was published in Pediatrics, and it was developing a specific clinical pathway for sleep disorders specific to children with ASD. And they focused in that study on insomnia. So what they did in their study is they did a systematic review of research on the treatment of insomnia in children with ASD. They started with a search of sleep disorders in children, and they had something like 1,700 articles that they were reviewing, and excluded all articles that weren't specific to children with ASD. And in the end, they had 20 articles left to review. And so my point in saying that is that as of this time, there is limited research on sleep disorders specific to the ASD population. They're out there, but by comparison to the general population, they're pretty minimal. After they did the systematic review, they also did pilot testing of the clinical pathway that they developed consequent to that. And they did a trial of that at 4 sites: Baylor University, OHSU, Kaiser Permanente in California, and then the University of Missouri. So this is the pathway that they suggested. And we have our own clinical pathway at Hope Central, which is largely based on this. We've got additional pathways for treating other issues: circadian rhythm, sleep disorder, restless leg, apnea, and so forth. But for insomnia, I guess the first message, regardless of sleep disorder, is that when you know that you're treating a child with ASD, it's appropriate to universally screen that population for sleep disorders. So every kid with ASD, at Hope Central, we have I think we call it a screening tool, but really it's a tool that the parents fill out, just sort of reporting symptoms and issues in various domains of the child's life, and one of those is sleep. So embedded in that form, we ask about sleep for all kids who we're treating on the spectrum. Once you've determined that the child has a sleep disorder or may have a sleep disorder, it's appropriate to assess medical factors that may contribute. And I guess I should back up too. As far as assessing whether a sleep disorder exists, there's a few common questions that I typically ask. One is I want to understand the child's bedtime, meaning the time that lights are out and the child is in bed. 2, I ask about the time it takes for the child to fall asleep. And a good sleep onset would be around 20 minutes or less from the time the child lays down. If there's a pattern of sleep onset latency where it's taking 40, 50, 60 minutes or so to fall asleep, that's a concern. I also ask about sleep maintenance. And one of the things the Autism Treatment Network Sleep Committee suggested is that you ask, does your child wake up once per night? They have found that for families that say yes to that question, that there's a good correlation with multiple wake-ups or other sleep issues. So they have sort of offered 3 or 4 quick screening questions parents could or pediatricians could ask, and one of them is, does your child wake up once per night? But maintenance of sleep is a challenging issue for kids with autism, so we ask about that. And then during those wake-ups, what period of time is the child awake? How long does it take them to return to sleep? And then I ask about the time the child wakes up in the morning. What time do they start their day? For families of kids with autism, it wouldn't be unusual to hear that the child wakes up for the day at some terribly early hour and is ready to go. So those are some of the questions I ask. I also ask about daytime napping, if that's happening, and any symptoms of sleep deprivation, like excessive sleepiness during the day. Does the child fall asleep in class? Does the child fall asleep on short car rides, like from school back home? Okay, so moving on, in terms of assessing medical factors that may contribute to insomnia, I'm not a pediatrician. I'm not going to pretend like I have an understanding of what all those factors are. But for those of you who are pediatricians, that's an important component of the pathway. Moving on, as far as once we've identified this child has insomnia, what are the appropriate treatment interventions? So the first thing that the Autism Treatment Network recommends, and this is the first-line treatment for most sleep issues in pediatrics, is behavioral and educational interventions. So making sure that the child has good sleep hygiene, that there's good practices around kind of bedtime routine and schedule of bedtime, and the child's not viewing television too close to bed or engaging in physical activity right before sleep, or all those kind of classic sleep hygiene things you want to look at. What I will say, and then going on to some autism-specific things, children with autism oftentimes like routine and structure, and they feel better when they can anticipate transitions and changes. And so one of the hiccups that you can see around bedtime is that the child is having difficulty transitioning from whatever they're doing into the sleep routine. So by offering some greater predictability around that, one, by establishing structure, but two, by offering other aids like visual schedules. Does everyone know what a visual schedule is? It's exactly what it sounds like. It's a schedule and pictures. And other transitional aids, any other aids that might be helpful. One of the things that we often recommend to patients, to parents of patients that we're seeing around transition issues are visual timers. There's a great app called the Time Timer where it's sort of like an egg timer, but it's on an iPhone or something, and you can see the little red pie getting thinner and thinner. So those types of visual cues can be very helpful in setting up a successful bedtime. And then thinking about sleep environment is important. I mean, this is important for all kids. We want to make sure that the sleep environment isn't too bright, it's not too loud, it's not too hot or too cold. So those are important for all kids, but maybe even magnified for a child with autism who has sensory issues. This is one of the things, as they've done research into sensory or sleep and sensory issues, this is one of the areas where it's been problematic, as the child is very hypersensitive to some sensory stimuli, and that's interfering with the onset of sleep. So helping to manage that. There are limited studies to date done on behavioral management for insomnia in children with ASD specifically. Most of the studies that have been done on behavioral interventions for insomnia have been done with a general population, not specific to autism. So the Autism Treatment Network recommends these behavioral treatments based on the presumption that they are still appropriate for kids with ASD. And those things would include things like positive reinforcement of staying in bed with lights out when it's time to do so, and things like that. So using positive reinforcement strategies. Extinction, and so an example of where you would use extinction is like if the child is in your needs you to be in bed with them to fall asleep, and you're trying to wean that, you're using extinction in that example. So extinction can be a helpful strategy in promoting sleep onset if there's a sleep association that's getting in the way. And then bedtime fading, which is where you identify the time that the child typically falls asleep, regardless of what the time in bed is, and then you're moving the bedtime later than that typical time of sleep with the hope that you're improving sleep efficiency so the child's not laying in bed awake for hours and hours and developing an association with a wakeful state and being in bed. So you're trying to improve efficiency first, and then you walk back the bedtime to a more desirable hour. That's another strategy that's typically used with a general population of kids. The fourth step in the insomnia pathway is if these educational and behavioral interventions have not worked, then you should consider sleep medication as an option. Currently, there are no medications, and I should say that my disclaimer here is this study was done in 2017. Maybe you're aware of more updated research, but at the time that it was published, there was no FDA-approved medication for pediatric insomnia, at least specific to the ASD population. There is some evidence, albeit small studies, that were done on the use of melatonin and have found that to be effective. And then if these things aren't working, then consultation or referral to sleep specialists would be appropriate at that point. The other thing to just add to this is throughout this process, it's important to do sort of that active follow-up. So when you do an intervention, it's important to sort of actively follow up and not assume things are going well just because you're not hearing from the parent again. So that is sleep in a nutshell, and I'm going to invite Dr. Jones to come up and talk about poop.
Okay, so I feel qualified to give this talk because I've been a pediatrician for 20 years, and so we talk about size and shape, and just this microphone, size and shape of poop all the time, and I've had 20 years of parents bringing me a diaper and ask me to look in it and feel it and touch it, and so I know that a lot of these recommendations are useful for neurotypical kids as well as autistic kids, but I want to definitely pull out a few pearls that are helpful, particularly in autistic kids. And we've worked a lot with this at Hope Central. We've tried to make ourselves a very comfortable and friendly place for kids with autism. So we've had 5 years of experience. We're certainly don't know everything, but And in this talk, we're getting close to lunch, so I'm going to try to avoid too many poop jokes, but it's pretty tempting. We'll just kind of see how it flows. So objectives. Objectives, we're going to just look at kind of how common is it in autism. We're going to look at how do you recognize it in autism, and then we'll talk about treatment. And we've got two kind of tools that you can use that are in your handouts that we'll talk through depending on time. So how common is it? It's common, and these numbers actually I don't seem to reflect kind of my experience. I feel like I see it really frequently in kids, but a handful of studies said that any given time, about 8 to 9% of kids will have constipation going on, but over their lifetime, about 44% of kids with autism will have constipation. So pretty frequent, and. What is constipation? Not something that needs a lot of dwelling on, but there's a lot of definitions. I think really it's about, like a lot of things, it's a lot about the symptoms. So is your kid presenting with large stools, painful stooling, blood streaks in the stools, and that's been going on for a period of time? Are they having abdominal pain, incontinence? And then it's always something I have in the back of my head when parents talk about their kid having poor appetite, when their kids having difficulty with bedwetting and toilet training, all things to have in the back of your mind in any kid, but particularly in kids with autism because it's so common and so frequent. So what's unique in autism is that, for a number of reasons, partly because sometimes it's hard to get a good history, it can sometimes present as just behavior change. And so it's a thing to talk about or think about when your parent comes in and is complaining about a behavior in your child with autism. So an example for me was a child I treated in Tacoma, and this mom was amazing. She had these two children, about 16 and 18. They were 250 pounds, great big kids, barely verbal. she was just amazing with him. And she said one of them, for several weeks, every time she would drive him somewhere, he'd sit behind her in the car, and he would reach up and he'd pinch her on the back of the arm. And she's like, what is going on? He's not normally like this. And we evaluated, and he had some history of kind of limited stooling and some fullness in his abdomen, and we treated constipation, and he stopped pinching her when he was driving. So think about it when there's some change, some frustration, some sign. And it doesn't have to be constipation, but certainly think about that as a change in behavior as a sign of some sort of pain. It could be something else, an ear infection, something else. But that's, I think, an important pearl for kids with autism. Oops, wait, missed it. Yeah. So evaluation, it's pretty straightforward. You can feel fullness potentially. You can feel on-rectal, feel some hard stool, see stool around the anus. But, in kids with autism, sometimes your evaluation, your ability to do an exam is limited, how much they want you to approach them. So a lot of times it's got to be based more on symptoms. You've got to flex, as you guys know, flex with the kid and work with what they will let you do. X-ray is often in the workup and listed. There are a lot of studies that show poor reliability from if this radiologist says this is a lot of poop and this radiologist says there's not that much poop, and then they test them and they switch images, it doesn't work out very well and there isn't good reliability. And so it's just, in addition, to do an abdominal film, it's a significant radiation exposure compared to, say, a chest X-ray. And so, it's just something I think I use it very rarely. I try to work without it and not rely on X-ray very often. So red flags, things to tell you that maybe you need to think about something else or do some other workup. If there's fever, if there's distension, anorexia, vomiting, particularly signs of obstruction, maybe like bilious vomiting, weight loss, poor weight gain, and some of the, this paper that we reference suggests thinking about thyroid and calcium and lead and celiac. Also potentially how emergent, depending on how emergent it is, you might need to send them to the emergency room, of course, or you might need to move them more quickly towards referral to GI. So treatment, and again, we're gonna look at a tool that you can use that lists a lot of the treatments, but some underlying things to think about. Consider the causes, potential causes. So in kids with autism, they often have restrictive eating disorders. An example would be a child who came in to me a couple months ago, and his dad said, well, he really loves goldfish, and that's pretty much what he eats. He eats a lot of goldfish. So your carbs are going to really slow down your poops. He's not eating much of anything else. And sometimes that requires feeding therapy because you can't get them to start eating vegetables, right? Fortunately, this kid had been very persuasive, and this dad was giving him what he wanted. And, in educating him on that, he was able to kind of cut off the goldfish and up the intake of other foods, and his constipation got better. So look at that, think about that. Again, you may need more help than that. It's usually not that easy. Usually you need feeding therapy or some other help. Avoiding withholding can mean that they've had some pain with stooling, and so now they don't want to go poop because it hurts, so they hold it in, which makes it drier, which makes it hurt more, which creates this cycle, right? So look for that in a cycle and look at how to break that cycle. Or Dr. Brasted and I were just talking about yesterday that sometimes they're avoiding the toilet because it's hurt to go to the bathroom. Now they don't even want to go in the bathroom. And so you've got to break that association of like, when it hurts, I go to the bathroom, and maybe slowly build the skill of going in there with some rewards so that they will at least go into the bathroom and use the toilet and keep that cycle going. And then medication. So a lot of the medications that are commonly given, antihistamines are often used to help with sleep or with behavior. Sometimes kids need iron therapy because their diet is poor and they have anemia, and so that can cause constipation. And then risperidone and aripiprazole can have side effects of constipation. So look at what medications they're taking. So the treatment pathway, I've got two, depending on what kind of a thinker you are. I'm a linear thinker, so the pathway that I and our team put together is more of a linear pathway, and then that's on page 31. And then one page after that, there's a pathway that's more of a flow diagram. I find flow diagrams, I tend to kind of go in circles, and I can't figure out which way I'm supposed to go. And but some people really like, my partner, Dr. Scott, really likes those, and so it just depends which one you like. So in the first pathway, the way it works, looking at it with me, and one thing, this is part of a bigger pathway that has sort of steps to the side that I realize aren't there. So if you'll notice, like the first box for each column describes sort of the explanation for that column. Then the next three boxes say baseline in parentheses. So that's sort of something you're going to think about at the beginning of your evaluation. And then starting 1, 2, 3, 4, on the fifth box down, just put a 1, and then 2, 3, 4. And that's sort of the steps that I would recommend considering in order with as you kind of see the patient. Maybe that doesn't work. Next time you see him back, you try step 2, then step 3, then step 4. So with that orientation, the column, first column to the left is sort of more mild constipation, potentially because they have no impaction or maybe it's not so severe. The middle column being a little bit more severe symptoms, maybe with impaction, meaning there's some stool that's stuck and not easily coming out. And more severe to the right with impaction, maybe with some red flags. So initial things to think about, as we talked about before, think about dietary restrictions, limiting fiber, consider feeding therapy, particularly if they have a whole category that they're not willing to eat, and even with education, they still won't. They will not eat a single vegetable. It's not just they don't like broccoli, but they won't eat broccoli, peppers, and anything green, then you probably need some help, and that's usually feeding therapy. And then kind of think about behavior changes, as we mentioned before. Potentially you probably, and what that box is saying is talk to your parent about recognizing that symptom and addressing it quickly with treatment, with Miralax, and then with also just helping with their behavioral association with being in the bathroom. And then avoiding and withholding, as we'd mentioned before, think about positive reinforcement to build their skills in going to the bathroom, positive reinforcement for sitting on the toilet. Sometimes just having a set time where you give them, I tell a parent, like set an every 2-hour alarm on your phone. When every 2 hours goes off, you just go sit on the toilet and read a book, and poop happens. And this is actually pretty useful for toddlers too, and particularly targeting those times after they've eaten, because that's the most common time where your body's going to be ready to have a poop. But if you can do that, use a reward system like stickers or something, and then build that skill and break that cycle of not wanting to poop. And then starting with treatment, so if it's pretty mild, usually you can start with working on dietary recommendations. So, up the fruits and vegetables, avoid bananas, limit carbs, increase the water, these kinds of dietary recommendations. And then, if that's not going well, then adding Miralax. Miralax is amazing because there's really almost no side effects. It always is going to work if you use enough of it. And, but it needs to be titrated up to a point where you get a creamy consistency. Some people describe it as toothpaste or peanut butter or whatever you want to describe it as. But, and making sure they're drinking plenty of water with that, because the way Miralax works is it goes to the lower intestine as a polymer, it pulls in water. If they're not well hydrated, it's not going to be effective. So they need to hydrate with water well. Step 3 being add senna as a softener, and then step 4 being considering a clean out. I realized we can send later maybe some information about how to do a clean out. I didn't include that in this. A clean out generally means, what I would recommend is, pick a weekend, because you're going to try to push them to the point where they're having just runny, clear stool over 3 days, and that's going to be doing a half cap to 1 cap, maybe even 2 caps, 2 or 3 times a day for those 3 days, to the point where they're just having runny poop and there's nothing left in there. And then you go to a maintenance dose of Miralax following that, of maybe a half cap a day or 1 cap a day. Again, do it over a weekend, because they're not going to be able to be in school. They're just going to have to kind of stay home and get through that process. But if you're failing, that's your way to make sure that they're cleaned out and they've restarted that pattern of not having hard poops. And then the one other piece of advice with Miralax that I like to give is, often parents will give it for 2 or 3 days, they have a soft poop, they stop, then they have a hard poop a couple days later, then they start it again, then they stop. And what you need, again, because kids often associate pain with constipation, and then they hold it in, and then they don't poop, and then it hurts, and they hold it in, you need to break that cycle also with the Miralax. So I always recommend treating at least 1 or 2 months straight and I let the parents go up and down on the dose because it's pretty safe. It doesn't, if they give a little too much, you're going to get diarrhea. That's the main consequence. If they give too little, it doesn't work. So I just tell them within this range, half a cap a day to 1 or even sometimes 2 caps a day, you can go up and down, and then keep the stool soft, keep a close eye on it, and give them at least a month or 2 of that kind of treatment so that they no longer have that association of pain with pooping. And then obviously you want to use medication forever, so stop it and see how they do. But in some of these kids, they need to very regularly just be restarted for a month, as they do better or worse because of their diet or because of some association between the GI tract and autism, which is not fully explained yet, but there clearly is something going on where these kids just often have constipation. So that's sort of how to use, and then basically in the more severe pathway, it just basically starts at a higher level of treatment sooner. So that's the use of that tool. Dan, how are you doing for time? I was trying to decide if I should do questions or 3 minutes. Okay. Again, the flow diagram's then on page 32, and I'll just briefly orient you to it, and if this is the way your brain works, then great. What it does is you just start at the step 1, and you follow and answer the questions, kind of coming down the left side. It's if you're seeing red flags, you need to work up those red flags. And for each number, the page after, it has some greater explanation of sort of what they mean by that step. So there's a number 2 on the next page, and it says, here's the things to think about for red flags and for your H&P. And step 2A is what should you do for your workup if you see red flags. So that's sort of how that flow diagram works. I'm going to open it up to questions, and I think the idea is that you can ask either Dr. Brasted questions or myself questions, right, TK? Yep. All right. Sure. So feeding therapy is something you can get through. There's for very severe feeding difficulties, Seattle Children's has a feeding therapy program that's multi-specialty. It is a long referral time to get in there, but that is for those really difficult kids where I'll send them. For the kids that are just, they want to eat a single vegetable, it's something often run by OT, and you can get it at like CTC. And some of those other places you can refer for that, and they do work around just, I don't actually know how they do their work, but they do their magic, and they work on slowly building up their tolerance of different things and can increase their tolerance of a more variety of foods. Good question.
I wonder if there have been studies to look at the GI tract in kids with or people with ASD to see if there are any differences than typical people?
Yeah, that's a good question. That was sort of I sort of made reference to, I think that's an evolving area of science. And I think if you Google autism and GI tract, you'll get a lot of information that with mixed reliability, and a lot of parents come with concerns about that. In terms of what's really well proven, I don't know yet. I'm sure some of the greater experts in autism could speak to that. Yeah, Dr. Stobie has a...
Yeah, so